Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this edition of the Doc Podcast. I am so excited to announce today's guests, Trish and John Hopper. Trish is with us now, and her husband, John, is going to stop in a moment to give his feedback on some of the treatment pertaining to their daughter, Lauren. Trish and John brought their daughter, Lauren, to see me back in 2019. It was actually a couple months prior to her 7th birthday. The main reason that Trish brought her in was one of her front teeth was quite protrusive, and they wanted to see if something could be done about that. But what happened at that visit is something that I see very often in practice, and something that, as you all probably know by now, I'm very determined to help educate both orthodontists and the public about. After performing my diagnostics, including taking a low-dose CBCT or cone beam X-ray, I realized that Lauren had more going on than just the crowded and protrusive teeth. I actually detected that she had sleep-disordered breathing and wasn't breathing properly through her nose, causing her to mouth breathe and snore. Since she was such a young skeletal age, I was actually able to use really light orthodontic forces with just braces and wires, not traditional expanders, to expand Lauren's arches and make more room for the teeth to erupt into the mouth. This also widened her palate and made more room for the tongue, which helped open her airway so she could breathe through her nose instead of having to open her mouth to breathe. It also created a very beautiful smile at a young age, which is a nice thing and something else we will talk about. So this entire process, we're going to kind of go through the journey and talk about Lauren's journey with orthodontic treatment and phase 1 orthodontic treatment. And we'll get into some really exciting things. And as I said, I am super thrilled to be able to share with you the parents of a patient who actually have experienced this technique that I talk about often in my podcasts and courses. So without further ado, I would like to introduce Trish Hopper. Welcome, Trish.
Hi, Mike. It's good to see you.
Good to see you as well. Thank you so much for joining me today. I really appreciate it. And it's funny because you and I knew each other from a long time ago. We went to school together starting back in kindergarten and hadn't seen each other for probably 25 years when you brought
probably about that.
Lauren in. And I remember we kind of had a good laugh thinking about the fact that we were younger than her when we actually knew each other and would ride the bus together, going way back to kindergarten years when you brought her in at 6 years, 10 months where she was. So it's a small world, and it's funny, the full circle that sometimes we travel. So before we kind of get into the details of what happened with treatment and what you saw happen with Lauren, if you wouldn't mind, just kind of take a minute to review how you ended up presenting to the office for that first evaluation, what that process was like, and what you remember about that first appointment.
Sure. So I had Lauren at her annual cleaning with her pediatric dentist. And I just had casually mentioned to her that I was a little concerned about Lauren's teeth being so crooked. One of her top front teeth was actually protruding a little bit. And we were a little concerned that if she was at school and she got hit with a ball, or if she fell, that she would actually lose the tooth. So we mentioned that to her dentist, and we said, what can we do about this? And Dr. Nikki had said to us, she said, she definitely has crooked teeth, that you can definitely see some of them are misaligned. She goes, she's definitely going to need orthodontic work. She goes, you might want to get her established as a patient somewhere. And, she's like, they're not going to put braces on her right now. But she said, it's, not a bad idea to get established as a patient. They can monitor her every, 3 to 6 months. And eventually when she is ready for braces, they'll let you know that, she's ready. So I knew right away where I was going to go. The DeLuke name in our area is really, it's synonymous with excellent dentistry.
Thank you.
And I knew you were an orthodontist. So it was a very easy decision as to
Thank you.
where to bring her. And we made an appointment with you and your office, and I brought her in.
Awesome. Well, thank you for that. I appreciate that. That's very kind to say. I have been fortunate to have many family members precede me who have done a lot in the profession, and I was fortunate enough to be able to join in that. So thank you, and I'm glad you did bring her in. It's interesting when you say what the pediatric dentist said, because that's super common. Again, a big part of the reason, which I'll probably repeat a bunch of times, but the big part of the reason that I'm so passionate about this is it's really it's not necessarily wrong what the pediatric dentist said. It's just there's this kind of a lack of understanding across the dental profession, not just orthodontists, but in the general practitioners and pediatric dentists that also don't even know what's possible at a younger age, especially as it pertains to airway, and helping prevent more work and more challenges down the road. So seeing as how when you brought her in, it had nothing to do directly with airway. Were you a little surprised when I started to show you this 3D image and talk about and starting asking you quite very specific questions about her sleep, her breathing, her airway?
Yeah, it just completely threw me off, to be honest with you. We were in there, first of all, I'm in there to, just establish myself as a patient. I'm thinking, braces not for another 2-3 years. Mm-hmm. And then, you're throwing in with the airways and the breathing. And I'm like, this is okay. This is interesting. I don't, it was definitely caught me off guard.
Uh-huh.
But it was completely relevant to what we were going through with Lauren mm-hmm. at the time. Lauren was doing some mouth breathing for quite a while, and I never thought of anything about it. Her mouth was open while she slept. It mm-hmm. wasn't a big deal. And then at one point I noticed she started snoring. And I thought, I'm like, a 6-year-old shouldn't be snoring, I don't Correct. Think. Mm-hmm. No, you're right. And I said, well, maybe it was just she had a stuffy nose. So, I gave it a couple of weeks. It didn't stop. Mm-hmm. And it seemed to, start progressing into, more and more snoring. And, I was really concerned about it. So yeah, it was very, the timing of us bringing her in just to get established as a patient and, at the same time going through these issues, it was just a pure coincidence and just, it definitely took me by surprise that you had asked about her breathing too.
Mm-hmm. Yeah, no, I remember. And it's a super common reaction. It's actually the most common reaction that I would get with patients and parents in that consultation. But it was always a very similar reaction is when I would see the things that I saw diagnostically, which led me to ask those questions, because plenty of 6-year-olds, 7-year-olds come in that don't have breathing issues and it's not a problem. Mm-hmm. But when I saw the things I saw in her diagnostic evaluation, and which leads me to ask the questions that I began asking, it's almost the same look the parents give every time. And it's this look of, number one, I'm at the orthodontist, right? Like you, and number two, like, mm-hmm. what, wait a minute. How did you know some of that? Like how could you tell that by looking at teeth? And mm-hmm. I actually remember you saying something like, I brought her here because I was worried about one front tooth and a little bit of crowding. And now we're having this whole conversation about her breathing and snoring and sleeping. And it was cool. And I love those interactions. And I think it's why it's so important that people in my profession take the time to look at the patient more than just the teeth. Look at them, understand what's going on in their growth and development. And you can tell a lot in that. So if you wouldn't mind, take a moment to just go into a little bit. She had seen an ENT prior to coming to me as well, correct?
Right. So, we decided, my husband and I decided that, this isn't normal. It doesn't seem to be resolving on its own. It didn't seem to be related to any kind of colds or anything. So mm-hmm. we brought Lauren to her pediatrician mm-hmm. first. And the pediatrician recommended a pediatric ENT in our area. Very good pediatric ENT. So we took her there, and he ended up putting her on singular medication. He didn't feel that at the moment that she needed like any kind of like adenoids taken out or tonsils taken out. He just said, let's start with, putting her on this medication and see what happens. So we did. We put her on the medication, and we noticed that it did help, but it didn't eliminate any problems. It didn't eliminate the mouth breathing. It didn't eliminate the snoring. Like I said, it did help, but it was still there.
Okay. And I also hear that often, and that's what's interesting in how multifactorial these airway problems are. And I'm always clear with people that it's not that the orthodontist is diagnosing her with sleep apnea. That requires a specific test in a sleep lab. And it's that the orthodontist can see the symptoms of an underlying airway problem. Had Lauren not seen the ENT, and I believe she saw Dr. Mouzakis, right? In this,
yes.
Yeah, and he's awesome. I've got to reach out to Jason. I want to get him on a podcast coming up here.
He is amazing, absolutely amazing.
He is just amazing. I was fortunate enough to work with him on the cleft craniofacial team, and he and I learned so much from him. I would pick his brain on this stuff, and this would have been a patient I certainly would have sent to Dr. Mouzakis had she not seen him prior. And these were some of the fun cases where he was kind of becoming amazed with what was happening, because these were, according to him, these were some of the tougher cases where there really wasn't a lot of like lymphoid tissue, adenoids, tonsils blocking stuff. Those are kind of easy. Like, oh, great. Okay, there's a blockage there. Well, let's go in surgically and get rid of it. But when there wasn't that, and it wasn't like she had these super narrow airways with terrible allergies, because her scans, which I can show as our viewers who are looking at the content on one of the video platforms versus just audio, I'll put those up for them. Her scans didn't show obstruction really of the nose passageways, where it's like, okay, she can't get air in through her nose, but it showed a really narrow, high vaulted palate, right? And kind of a V-shaped arch, and kind of not a lot of room for her tongue. And so these cases are great examples where you say, okay, well, there's really nothing obstructing air going in through the nose and down into the lungs, but her tongue doesn't have a lot of room. And because everything's kind of squished in, and the teeth being crowded are really just the symptom, the cause is that the arches are narrow and the tongue gets pushed back and it kind of blocks the air from getting through. What do they have to do to breathe? Got to open their mouth, and they've got to open their mouth to pull that tongue away from the throat so that the air can get in. Well, then the path of least resistance is the mouth. So they just breathe through the mouth. And then as the tongue starts to fall back when they're sleeping and essentially lying supine so that the tongue can fall back and occlude the airway, you get that, the snore, and it goes from there. So when I see these patients who had already seen someone amazing like Dr. Mouzakis, Singular is a great call, because it's a minimally invasive way to see maybe we're missing something subclinically here. I used to hear that all the time. Yeah, maybe a little improvement, but something's still not right.
Right.
Then we come in and we talk about orthodontia. Now, was she having what did you notice in her as well, school-wise, behavior-wise? Was she tired? Talk a little bit about that for some of the parents who maybe have a child who is experiencing some of this. What were some of the things that, looking back, you could say like, well, yeah, she actually had some other things going on?
Yeah, she wasn't getting good sleep at night. She couldn't. Her snoring was loud enough that we were able to take a video of it, which is what we brought with us to her pediatrician. We brought the video with us to the ENT. So, it was significant enough. You knew she was not getting enough sleep at night. And she was for a 6-year-old who is supposed to have a lot of energy, she was tired. She was tired during the day. And, it seemed to The exhaustion seemed to really tie in with the progression of, yeah, I'm just mouth breathing right now, but now we're starting to get into some snoring, and we did wait before we brought her into the pediatrician just to see if it was a cold, maybe it was allergies, maybe it will resolve on its own. And as as that progressed, we did notice she was tired. I mean, she wasn't sleeping at night, and she was tired.
Yeah. Yep. And that affects everything with any of us. I mean, I would say to parents all the time, I mean, think if we just, get a few nights of really interrupted sleep, right? When our kids are little ones, or stressed with work, or just other family or work obligations, and, you feel it, right? And we should be able to kind of overcome that. And as adults, we can't. You think of these kiddos every single night like that. They're just in this, and with us, maybe we can catch up on a weekend, or, after a few days. They can't. They're literally unable to get deep, restful sleep night after night. And that's what I hear often too, what you just described. It's this kind of cumulative process. I think people sometimes think it's like, well, one day your child just has this problem. It's really not. No, yeah. It's more this progression, and it's this progression. And as parents, because, I would have oftentimes parents would come in, sometimes they'd come in much later, say it was 9 years old, and the parents like, oh my gosh, like, just like you said, I knew it. I knew something was wrong. You guys caught it really early. You were fortunate. You were very proactive with the pediatrician. The pediatrician did a great job, because I've had a lot of cases where the pediatrician might say, oh, they're fine, they'll outgrow it, type of thing. So your pediatrician did a great job getting them to a phenomenal ENT, and you had really good intervention there. Sometimes parents will mention to the pediatrician in passing. The pediatrician's like, oh, they're growing normally, they're doing okay. And then this kid starts to suffer more and more and more, and school's really impacted. And then the parent finally, when I have the conversation I had with you, and we uncovered some of this stuff, is like, I knew it. Why didn't anybody talk about this? So it really is a problem, not just in the dental profession, but in the medical profession. And it should proceed like what proceeded with you and Lauren. And that really was the ideal, but in a lot of cases, unfortunately, it's not. The part that I now was able to do when I talked about it, realized this was what was happening. I remember, because you had heard of expanders, most people have. And I remember talking about, well, we're going to expand her, but not with expanders. I'm actually going to put this 6-year-old in full braces. And I remember, about that look that you were like, what? And actually said, like, wait, what? Like, wait a minute. So would you tell me a little bit about you can be as blunt as you want, and what was going through your head, and kind of what did you think when I said we were going to help her mouth grow with full braces at that age?
Yeah. So, well, there were, some mixed feelings. Like I said, we had made the appointment with you just under the understanding that we were just establishing Lauren as a patient with you, thinking that we were just going to, keep an eye on her. You'd let us know in a few years when she needed to have braces on. So I was definitely taken back when you said, we're going to expand her palate and straighten her teeth, and we're going to do all of it with braces. Yeah, I was definitely taken back by that. There was a lot of thoughts that went through my mind. One of them being, thank God we were not putting her in traditional palate expanders. I personally have never had them, but I have talked to a number of parents. I knew kids when we were younger that had them, put in, and it just seemed just horrible to me. I had actually, even told Lauren, that she may need to get these expanders put in the roof of her mouth, and there's a bunch of metal, and we have to turn keys, and the pressure for the, a couple of days, and how painful it was going to be. And, all of this is running through my head. So on one hand, I was relieved that you said we were not going to do traditional expanders. And I think when Lauren got home too, she was like, Mom, I don't have to have that thing pushing in my mouth. I said, no, you don't have to do that. I said, that's, it's absolutely amazing. So on one hand, I was just grateful, just absolutely grateful. that we did not have to put our 6-year-old through that. And on the other hand, I'm obviously very nervous about putting a 6-year-old in braces, to be honest with you. I do remember calling your office, I believe 2 days before we were scheduled to have Lauren's braces put on, and saying to them, have you done this before? Have you
are we the first time? Is this first time?
Put a 6-year-old in braces before? Because I think this might not be right. And they assured me it was the day I had called. She goes, we actually just did braces on a 6-year-old this week. And I was like, okay, all right, well, Lauren won't be the first one to have the braces on. And just thinking back to, she's 6. I mean, can she take care of these braces? Can she, is this, too, going to be too painful for her, having, to have the braces adjusted. I remember having to have braces adjusted, and there's, 2-3 days of taking Advil and Tylenol. And, is she going to sit in the dentist chair long enough for you to put, and still enough for you to put braces on her? Is she going to want to go back after she gets braces on and after she gets the wires tightened up? Is she going to want to even go back? Are there going to be tears? I mean, she's sick. She didn't understand. And I obviously, as her parent, have to make these decisions for her. So yeah, I was grateful, and I was a little scared too. So yeah, and we actually, I do remember at one point when I had called 2 days before the appointment to say, hey, have you guys done this before? I was considering waiting until she was older, to be honest with you. But we put our faith and trust into you, which I knew I could. And here we are.
Well, thank you. I appreciate that you did. And again, that story it just echoes what I've heard, what so many parents over the years have told me. So you're not alone in any of those thoughts, or that call you made to the office. We got that call, and sometimes people called 3-4 times to ask. And ultimately, there's so many rewarding stories where they went through with it as you did, and which we'll talk about in a moment, some of the amazing changes, what the experience was like, and some of the amazing changes that we were able to achieve with Lauren. It's also interesting because in the courses I designed for this, and when I teach this to colleagues, I really emphasize the fact that it's more than just like throwing braces on a 6-7-year-old kid. It is a process, and you need to take the parent and the patient, parent or parents and the patient, on a journey so they understand this. Because if you just have a family walk in, I don't want to speak for you, but I'm guessing had you come in and I had just been like, yeah, you know what, we're just going to put her in full braces, and had it, the folder we give with educational materials, the way my treatment coordinator was trained, the way my front end team, to be able to educate and have an experience where you understand, okay, there's something to this. I think a lot of patients and parents just wouldn't do it, because they would just think like, this is great. What's the point? What are they really doing? But by educating, teaching them what the problems are, airway aside, but in Lauren's case, that was at play as well. It helps you have the confidence to say, okay, this isn't just some random thing. This is something they do and it's working, and it actually works. Is that a fair assessment?
Yeah, no, that's definitely a fair assessment. And I had, like I said, I had talked to my husband about this as well, who, he understands airway management much better than I do. And he basically was like, you need to do this. Like, it makes sense. And we're not just doing this, we are doing this to give her a beautiful smile. Yes. We are doing this to help that one tooth that's protruding not get knocked out. Yes. But, there's a bigger underlying issue here. And, the way you explained it to us, the pictures that you showed to us, the folder that I was able to bring home to him, to show, it just, it was hard to, make that decision. It was the right decision. It made sense to us. and our only concern is can she handle this? How is Lauren going to handle this? But yeah, I think if you had just randomly said, oh yeah, we're going to put braces on her right now, I would have been like, are you just looking for another patient here?
Right, sure.
But the fact that, you could see even before I told you she had breathing issues, you could see those breathing issues. It just, the whole thing, it made sense, and it made us much more comfortable with the decision to go ahead and do it while she was 6.
That's well said. Yeah, that is often the case, and something why I believe so much in teaching the process. And I'll now get into talking about Lauren's experience teaching how to put braces on a 6-year-old, because as orthodontists, I think a lot of us conceptually, just the way our educational system works, and you and I have had this conversation when you've asked questions about why aren't others doing this at the end when you saw what happened. And I said, kind of the way our educational system works, we don't get a lot of 6, 7-year-olds that we can really treat. It's a long story, and I won't go into it in great detail, but the point is, in our residencies, not a lot of orthodontic residencies, which are 2 to 3 years after dental school, do you get to do a lot of treating 6-year-olds or 7-year-olds, unless there's like a really bad crossbite in the back or something. So it's not super common. You take someone like Lauren, who didn't have a crossbite, had some crowding and one protrusive tooth, and you do much on them in your training program. So you really haven't been very well trained on putting braces on a 6-year-old, which is different than putting braces on a 12-year-old. It's still braces. The technology and the technique is the same, but the patient management is quite different. And you have to train your clinical team, your front end team. There's a whole process that goes into it to get this 6-year-old comfortable. I'd even say 6 to 8-year-old comfortable with getting full braces on, sitting for long enough, having enough ways to distract them, telling them, showing them before you do it. So if you would tell me a little bit about what Lauren's experience was like, and what as parents, yours and John's experiences were like, having a 6-year-old go through getting braces on and having them in braces.
Yeah. So, just stepping back to like our very first visit with you, walking into the office for the first time, it was beautiful. It was state of the art. The staff was absolutely incredible. They had taken Lauren to do some original x-rays and pictures. And, when I had talked to her when we got home, I said, was it okay? Because she had to go into the room without mom. She goes, oh yeah, they were talking to me and telling me funny stories. And she just felt very comfortable. I remember I sat in with one of the office managers, and she was going through things with me. And so that initial visit, we just were both incredibly comfortable with the staff. And I think, having that relationship is, right off the bat was key for both of us as well. And so, she had the braces put on. She was a little nervous about it, but she had the braces put on. I know you guys had headsets for her and TVs for her. She was totally distracted. She had absolutely no idea what was going on, which was great. And she sat still for the whole entire, process.
She did awesome.
And yeah, she did. And it was easy. Getting them put on was easy. She obviously, I think it was the first week, she was a little uncomfortable with the braces on, and that was to be expected. I know your team had a handout for us that I reviewed when I got home, and it specifically said they may be uncomfortable. Here's what you can do, and here's how long that discomfort may last. So that was all normal. That was all, definitely expected. She got past the discomfort. She thought the braces were literally the coolest thing in the entire world, especially after she got into school and she showed her classmates, who are all 6 years old, that she now has braces. She was like an instant hit.
That's
she was
amazing.
like, the coolest kid on the block. Unlike when I had braces and, you know, you're in middle school and you're subconscious of everything, and you're just, you know, image is everything. She was 6. Yep. They thought she was the coolest thing in the whole world. So that was definitely fun for her. She had no problems. We had no problems. When she had to go in and I thought she had to go in and get wires tightened. I was pleasantly surprised that we did not have to have those wires tightened. And go through all that. You know, she did have to have wires swapped out, and, you know, we would come home and I'd be like, how are you feeling? Are you doing okay after the wires? Yeah, I'm fine. I'm totally fine. And she never minded going to the appointment. She said all of the girls were so nice. Dr. Mike was so nice. It was like family for her. She was super comfortable. I never had to drag her there going, oh, I don't want to go. I don't want to go. She was comfortable. She was comfortable with the braces. She was comfortable with you. She was comfortable with the team. It was very, very smooth process for us.
I appreciate that so much. And that's our goal. It was always my vision for the practice to make the patients feel that comfortable. And that's why when I started doing this younger and younger, it was super important to me that I put the systems in place and train my team in a certain way so that we could make a 6-year-old feel that comfortable, and that patient's parents, because that's such a big part of it. And I can promise if she had an upper and lower expander, she probably wouldn't have gone into school showing it off as much.
No,
you know, the speech would be affected, and you take these kids with these narrow mouths and you've got this metal in there and they can't talk and their tongue is getting ulcerated. And I did it that way. I did it that way for probably 6 years or so before I started doing it. Around 2011 was when I started doing it with full braces instead of with expanders. And I mean, I just saw this transformation in how it affected my practice, my patients, my team, morale, parents. I mean, the tears were gone. It was not uncommon to have a parent and or patients in tears in the back, screaming, people, you know, trying to crank the key and gagging. And, you know, you'd put them in on a patient, you'd sit them up and they're like, you know, trying to breathe and talk. And again, it was better than pulling teeth, and for sure. And you'll never catch me saying expanders don't work or there's not a place for them. It certainly was better and more proactive to address these issues and widen and grow than it was to extract teeth in a case like Lauren or similar, and then close that space up and bring everything together and close it down. And so it certainly is a far superior approach to that. But once I found braces and wires, that if you got them young, again, the key is they have to be younger. You can't, this wouldn't have worked at 11, 12 to do it this way. But when you get them young and they're so pliable and they're so adaptable, if you can teach them, and we can with the systems we put in place, that this really isn't a big deal and it's super easy. And like you said, put the headsets on, watch the movie, nothing should hurt, raise that hand if anything doesn't feel right. Once you get them comfortable with you as a team, and Lauren was, and I'm not just saying that, an absolutely outstanding patient. I mean, she behaved more like patients, you know, a few years senior to her, just in her overall temperament. She was just so, you know, always, of course, nervous in the beginning, but just such a great patient, so mature in the way she approached the whole thing. And that's not always the case. Some kids are really, really high anxiety on this. And we prided ourselves on even being able to get those kids to really come around and trust us. And like you said, they come in for that first adjustment. They're fearful again, right? They're now used to the braces. They've got it and they're worried. And then I'm like, wait a minute, like they didn't like cranking it, tighten it, like it, just swap the wire out and go. And maybe a day or two, their teeth feel a little different, and that's it. And that's what we shoot for. So it makes me super proud and happy to hear that. And that's why I put so much time and energy into the teaching of this, not just, again, throw braces on, because you could lose a patient. You take a 6, 7-year-old, you don't give them the experience you're talking about. You sit them in the chair, you go to pop braces on their teeth quickly, aggressively, you're going to lose a lot of them. You know, Lauren, probably, she's such a good patient, such a good kid. She maybe could have withstood it. It would have left some emotional scars on her there a little bit about wanting to come back, but I think she could have tolerated it. But a lot of kids who don't have that level of maturity, I mean, they'll be out of the chair. I mean, literally, you'll lose these kids. They'll jump up and can get out of there. So it is so important to have that side of it. And I'm really pleased to hear Lauren had that experience. So as she's going through this, and then in a moment we'll bring John in to get his take on this part as well. So if you would kind of set the stage for, obviously you start to see the teeth straightening quickly, because that part happens pretty fast. And then what else did you see as far as airway, breathing? Just kind of take us through that.
Yeah, so we did notice her teeth straightening up very fast, very, very fast, much faster than we had anticipated, which, was fabulous. And I know you had mentioned at one of our appointments, you had said to us, any kind of, airway change, you may start to see at about I think you had told us originally about 4 to 6 months.
Yep, exactly. Yep.
We got to, I would say it was more like 3 to 4 months. We were on the early side of what you had said. It was 3 to 4 months. And oh, wait a minute. She's not snoring right now as she fell asleep. She picked up maybe an hour later, and then maybe like a week later, we would be like, oh, wait a minute, she's not snoring as, and it wasn't an instant like, oh, she's got no problems anymore. It was gradual. It was a very gradual process. It didn't take too long. And it was just, week by week, we were like, I think this is better. And, we were crossing our fingers, and this is definitely getting better. And then I think just we hadn't paid attention. I hadn't paid attention to it for a while. It had been a couple of weeks, maybe a whole month had gone by then, and I go, wait a minute, she's not snoring tonight. And I don't think she was snoring last night either. And eventually the snoring was gone. The obstructive sleep apnea, it was gone. And she, for the first time in a very long time, she was actually sleeping with her mouth closed. And, I'm next to her while she's sleeping with her mouth closed going, is she breathing? Like her mouth, it was so unusual for me to see her with her mouth closed. I got my finger like under her nose. I'm looking at her chest rising. I'm going, is this kid still breathing? I'm
what did these braces do? Wait a minute.
We didn't want to, at first we were just like, what's going on right now? And we didn't want to celebrate, and we didn't want to, say, oh my God, this worked. And this is, but yeah, as time went on, it was resolved. The sleep apnea, the mouth breathing, the snoring, it was all resolved. And we stopped giving her the Singular, and we have not put her back on it since.
It's just awesome. It's just awesome. And
it was awesome.
I can't tell you how much I appreciate you sharing that with colleagues and parents, anybody who listens, who maybe has a child in a similar set of circumstances. And I always tell colleagues when I teach or lecture or teach residents, I don't ever go out there. You can correct me if I said this to you. I don't say braces or expansion cures all sleep issues, right? Nope. Cures pediatric sleep. That's nothing. I don't promote it as that. You would never see anything in my office in any literature that says, do braces to stop snoring or stop to breathe better, right? That is not it. What it is if you take the time to diagnose the problem, and you get a good history from the parent, you look through your records, cone beam, 3D imaging definitely helps. And you put the pieces together, and then you realize that the tongue didn't have room, as we explained before. And now that you make things wider and not like nearly narrow and tiny, that tongue can fill out that area, and they can close down, and the tongue can come forward and rise up against the palate where it's supposed to rest, freeing up the airway at the back of the throat. It's not really rocket science as to why it works, but for some reason, we struggle in my profession to make that connection. And I think sometimes, sadly, people do go the other way. You're always going to have kind of extremists in anything that are kind of like, oh yeah, throw braces or expanders in every 6 or 7-year-old that comes in. And absolutely not. And I mean, I've had numerous patients that I put on observation and didn't do anything young with because they didn't need it. So, that's I think is an important point. And the story you tell is one I hear and heard so often. And it's why I also say I've been blessed to have created a lot of really nice smiles throughout my career, but nothing hits home as much as a story like that, where you really change the quality of life of a young growing kid and change the family's quality of life, because Lauren, you had said, all of a sudden was acting more like a well-rested kid, right? And do you want to just mention, like, in school and her behavior improved in ways that you maybe didn't even realize where there were some other issues there until you're like, wait, now she's sleeping. So she was behaving differently, right?
Yeah, no, I mean, after we did notice, after a whole night's sleep for, weeks and weeks and weeks, that she was just a different kid. Mm-hmm. She was well rested, and you mm-hmm. could tell that she was well rested. And in the morning, she just, had this big personality, and I'm awake and I'm ready for school. Mm-hmm. And it's just like, whoa, where is this child coming from now? She was well rested. Her personality, came out, and happy kid. And yeah, it was definitely a huge improvement that I think we didn't even know mm-hmm. That we needed, or that she needed, until we saw it. And then we looked back at, she used to be groggy in the morning. She used to be slow in the morning, mm-hmm. to get ready. And now she was just like, okay, I'm ready, let's go. And it was definitely a change that, we couldn't see until we, looked back and compared how are we now versus how were we when, she wasn't, she wasn't able to breathe at night.
Well, that's awesome. And that's what it's about. That's why I'm so passionate about it. That's why I'm devoting the rest of my career to teaching this and getting that message out there. And again, as I've said many times, that's why I so appreciate you being willing to share this. I think at this point, if we could, I know John, unfortunately, is struggling with a little bit of a head cold, but he's willing to pop in with us to just go over some of what he saw. So if you wouldn't mind, maybe before he steps in, just give a little bit of John's background professionally and what were some of the things he was doing that he noticed as well.
Okay. So John is a CRNA, which is a certified registered nurse anesthetist. He basically provides anesthesia for work. He manages airways on a daily basis. So when I did notice that Lauren's, she was snoring. I did ask him one night, I said, listen, can you come in and just listen to her? And so he came in the room after she had slept and noticed that, he goes, well, yeah, she's snoring, but she's also obstructing. Mm-hmm. And I didn't realize that was happening until he came in and was like, she's actually obstructing. Mm-hmm. And I said, I don't know what that means. And he goes, there's small periods of time where she's not breathing. Mm-hmm. I'm like, oh my God. So what he would do is, and he can talk a little bit more about it as well, but he would come in every night after she went to sleep and he would adjust her pillow. Okay. And he would try to get her neck to a point where, she was getting more air. Mm-hmm. Yep. Into her airway. So, and he can, probably talk a little bit more about that side of things.
Great. Yeah, I'd love to have him. If you want to let him know, we can have him pop in if he's okay with that and tell us a little bit about that.
Yep.
Hey, John.
Hi, how's it going?
How are you?
Oh, great.
Oh yeah. Sorry you're not feeling so good. That's
all right.
Not fun. Well, thank you so much for taking the time to just pop in. So Trish and I have just been kind of going over the progression that Lauren went through. We spent some time talking about mm-hmm. the consultation and how that was, almost off-putting in a sense, where it was like, wait, what? Yep. Braces this young, and how I started talking about airway, and with your background, as a CRNA, you just have a tremendous background in airway. So Trish had mentioned to me, you were seeing some things, you were recognizing some things prior to Lauren coming to me and us helping the mouth grow. Would you just take a moment to kind of talk about what you were seeing and then how you saw that change as she was progressing through her orthodontic treatment?
Yeah. So when we were, as Trish had mentioned, she had said that she had seen her Lauren snoring, and she had me come in to go take a look at Lauren, and I recognized that she was totally was obstructing quite frequently throughout a short period of time. Mm-hmm. So I would adjust her pillow. Sometimes I would do a little jaw thrust, a little adjustment of her jaw to kind of allow her to open her airway a little bit. Mm-hmm. And that would help. But as she would change the position throughout the night, she would also then begin to obstruct again. Mm-hmm. So it was quite a period of time where we were basically going in throughout the night and basically repositioning her and changing her position just so that way she wouldn't be obstructing as much throughout the evening. And as Trish had said earlier as well, that with the singular, it helped a little tiny bit, but mm-hmm. it didn't fix the obstructing pattern. Mm-hmm. It didn't fix the snoring. It made it better, but it didn't relieve any of those things. Mm-hmm. And as we saw the pictures of her at the beginning of treatment, you could see that she has this narrow palate, mm-hmm. this one protruding front tooth, mm-hmm. and when you read about obstructive sleep apnea, people with high arched palates have much higher incidence of obstructive sleep apnea.
Yep.
And you talk about, Trish came home after meeting with you and having a consultation, and she had said that you were talking about expanding her palate. And as you expand the area of the palate, you decrease the risk of obstructive sleep apnea mm-hmm. and other, just sleep disturbance breathing. Mm-hmm. So those things sounded great to me. And she was a little concerned about doing it so young. Mm-hmm. And every time we would sit down at dinner and have this conversation, should we do it? Should we not? And I'm like, well, the thing is, you think about children, and they're so much more pliable, so much mm-hmm. more malleable at a young age.
Exactly.
That when you expand their palate at a young age, it doesn't cause anywhere near the amount of discomfort mm-hmm. as it does when you get older. All those bones become calcified, the palate, all the suture lines start to get calcified or ossified.
Yep.
And then you have to put in those bars and expand it with so much more force.
Still correct.
Whereas that little wire, just when you have a very pliable, malleable palate, becomes so much easier and so much less painful. And you could look, literally just looking inside of her mouth, you can see the difference where she had this huge, large, high arched palate, mm-hmm. and now it's much flatter. And you can see the difference in her breathing and just her activity and just the brightness in her eyes mm-hmm. from a day-to-day basis.
It's so great you mentioned the eyes.
It was quite a dramatic change.
It's so great you mentioned the eyes on that too, because the before and afters, which I'll put up kind of over us as we're doing some of the talking, for the ones who are seeing, and if you're listening mm-hmm. on a listening platform, you can just hop on YouTube or Locals and you can see the video version. But her eyes before and after, and that was one of the things that helped me start asking Trish questions at that first visit about Lauren's breathing. She had really tired eyes, and I say to parents all the time, like, we can have tired eyes as we're raising the kids, but the kids are not supposed to have tired eyes. So unless they were, which is why I asked Trish, is she something acute going on? Is she cold, sick? Obviously mm-hmm. those things play into it. But if she's otherwise healthy, there's no reason for a 6-year-old child to look that tired. The before and afters, you could see again that mouth was narrow and the lips are pursed and the lower third of the face is kind of sunken in. After mm-hmm. it's just so beautifully, naturally full. And that's one thing I noticed in doing it with braces and wires young. And your explanation for that, by the way, is better than mine oftentimes. So thank you for the way you laid that out. But that's exactly it. By doing it young, when they're so pliable, it's so comfortable. It's so minimally invasive. The suture is not fused, as you said, so you don't have to put all these pounds of force to blow it apart. And everything you just described is exactly 100% correct. And the impact that then has on the airway by making more room for the tongue, and then the tongue can sit up in the palate, and the tongue plays a big role in helping shape the palatal growth. So now if it's sitting where it should, it'll keep that going. And the above the palate is the floor of the nose. So in Lauren's pre and post images in her 3D, I slice it. And in some of those slices, which I'll put up, you can just see the width of the floor of the nose increasing. The shape of the palate you described exactly that shape. When you take a coronal slice and you look at, you kind of remove the front of the face there and look at that shape, before that height of that palate was this narrow arc, and it's this beautiful sort of broad arc. And all of the things you described are exactly why we do it. And then what would you say as sort of, what did you see in her sleep, which I don't want to minimize, by the way. We always talk about how important this is for the patient, and it is, but for the parents, I mean, stop and think. We all know we have little ones that are just, in their first months of life, getting up throughout the night, and how that is. I mean, you're minimizing it and because being great parents, but that's a tremendous commitment to be up throughout the night after your guys are working hard, to have to watch her sleep. So from a quality of life standpoint for all of you, if you wouldn't mind talking about how it changed, a few months into treatment, or started to change a few months into treatment.
Well, just in the fact that after, a short period of time, we saw a dramatic change in her ability to be able to breathe and to exchange air. So that makes you feel much more comfortable. It gives you, the comfort of knowing that you don't have to sit there with her and hold her jaw all night long, and make sure that she's breathing. And from a long-term perspective, you think about the long-term effects of obstructive sleep apnea, the cardiac effects. People don't think about all of those things. You start getting right-sided heart failure, and then there's a ton of other physiologic changes that occur, and it's for me, it was a huge thing for. As soon as we started to see the changes, it was phenomenal.
That's great. And they've, as you said, go ahead. Sorry.
It was great relief and weight off of our shoulders, seeing that she was having a much easier time breathing, much less work of breathing. And that basically just led into her having more energy throughout the day, and just starting to be a kid again, because it seemed like she was just exhausted all the time.
I love that saying, it's getting to be a kid again, because another thing I say often, at 6, they shouldn't have to worry about breathing, and as providers, whether we're in the dental side, the medical side, we really need to be aware of this. And I so appreciate you sharing that, because unfortunately in my profession, you can look at literature going back to a guy named Bogue, who wrote a textbook on treating young kids in the early 1900s, and whether you should be treating them young or waiting. And so we've argued about this for over a century in my profession, but we still don't, even though there are lots of data out there and literature to support the expansion, as you very well laid out, expansion helping open the airway. For some reason, there's this sort of disconnect in my profession between us being able to do something about it proactively, or like, well, if we go in and expand them, they may get some airway change. So I'm working so hard to shift that paradigm, to get orthodontists to think about this differently and say, wait a minute, you've got a 6-year-old child that if you let them keep going on this path, not only is it harder to reverse that, but think of the neurocognitive effects, think of the cardiac effects, the overall physiologic effects, the psychological impact, and so on and so forth that this makes on them. And we're just going to chalk it up to they're too young at 6. Like, why? I mean, so, it's, I guess the last thing I'd say is, what would you say to other parents out there, or to other, and to other orthodontists out there about whether it's too young to go in and try to help these patients grow at 6 years old?
At 6 years old, I think it's the perfect time to start that. especially if you start seeing a child that has, decreased energy, or as you said, those those tired eyes. That is the time, if not earlier, to recognize those signs, and begin treatment, because all of those small little changes at a young early age add up to dramatic changes as you get older and older. And the treatment process is much easier and less invasive than as you get older, just because you talk about the calcification of all the suture lines, and just the palate is so much more rigid afterwards.
Yep.
You look at as you were talking about the literature of surgical procedures for obstructive sleep apnea in adults. You're doing the Lefort fractures and facial manipulation. You're changing the whole structure of the mandible and the maxilla to basically open up the whole upper airways. It's incredible the amount of work that has to be done afterwards. Whereas if you do a little bit of preventative maintenance or preventative procedures in the beginning, you don't have to worry about any of those things.
That's so well said. And then you're also trying to undo the muscle memory, relearn the swallowing and posturing and jaw posturing, and then how you naturally, as you were trying to astutely do with Lauren, get the neck in a better position. Well, as we age, we naturally, we get to be in our teens and adulthood, we'll probably be sleeping like that naturally. So now there can be neck issues and so on and so forth. So it's this cascade of events that if we can see it young, and as I said, when I was talking to Trish about this, it's not like every 6-year-old needs this. And that's the thing I think that is sadly I think there's a couple out there who just try to push this on all people, and that really paints a broad brush in a way it just shouldn't over anyone trying to do this. But the point is diagnose it, see if you see a problem. We wouldn't be having this conversation right now if when Trish brought Lauren in for that first visit, it was just the tooth. There were no airway issues. She was fine. We would have talked about lining those front teeth up so she didn't have a traumatic situation with that tooth and wasn't self-conscious about it. And that's the end of it. If she wasn't narrow and had breathing issues and so on and so forth. So it's about diagnosing the patient. It's about understanding airway and its implications in growth and development, and then knowing what you can do young with minimally invasive techniques and technologies to give the patient and the parents a good experience that's stable. And when Trish comes back on, I'm going to have to talk a little bit about that side and retention too, and where Lauren's at now with it. But the stability of it and the ease of it, and it really is something that I take a lot of pride in being able to do that. So I can't tell you how much I appreciate you sharing that and what you saw on your side, especially with your knowledge in the arena of airway. And I was saying to Trish, and I'll post it up, but her total volume increased by 50% on her 3D volumetric analysis. And it's a static image. It's not dynamic, but you can see the shape of her airway. You can see pre and post. You look at that 3D volume, total volume from up towards the nasopharyngeal area down towards the oropharynx increased by 50%, and her cross-sectional volume, or her minimum cross-sectional area, increased by 36%. So
that's huge.
I mean, you're taking a garden. I always tell people it's like a garden hose, right? If you're push stepping on it and that water's not getting through, and you let off 36% change, think of how much more water's going to get through.
Exactly.
And you've increased the volume of that hose by 50%. It's tremendous. And that's why she started breathing better. And then she cannot have to be on Singular her whole life. And then after that, she's on another medication because, as you said, it has cardiac implications. And it's just this cascade that I'm just so passionate about. And I just can't tell you how much I appreciate you explaining it, not only as a parent, but with your knowledge as a CRNA to be able to educate and provide that input is just so valuable.
Yeah. No, it's great. We greatly appreciate everything that you've done for her. Thank you.
Well, it's my pleasure. Thank you. Thanks so much for taking the time to do it. So, and especially not feeling great. I really appreciate it. So thank you.
That's right.
And if you want, I can have Trish hop back on. We'll just finish up and
sounds great.
From there. Awesome. Thanks so much, John. I appreciate it.
All right. Thanks, Mike.
I can't use all those fancy words that he uses. I'm just a mom opinion.
No, you know what though? And this is something that I find all the time. Moms have instincts dads don't have. Had a lot of patients and parents in a consultation room, and I've met with a lot of patients and parents over the years. moms pick up on things and they just sense things in their kids that as dads, we don't. I mean, it's not indicting the dads in this. It's just, we just don't pick up on certain things. The moms just have this instinct that we don't have in certain ways when it comes to things like this. So the input of you as the mom with your maternal instincts and sensing things with your child, and then have John's input as the expert who understands the biology and physiology of that, is just, it just speaks volumes to why you both were so aware of this, why you both were willing to have Lauren go through this, and why you both can speak so comprehensively and in such an educated way about it, because you both were very much in tune to it. So no, it's a really nice compliment, and I give you guys a lot of credit for making the decision to do that for her and not just chalking it up to maybe she'll outgrow it or is it worth it, because and that's really I hope to motivate not just my colleagues to take patients down this path when they need it, but also motivate the public to push, to ask their providers questions. And if a mom has those instincts or a dad has a background in this, to say, wait, doc, like she shouldn't be snoring. She's 6, like you said, or she shouldn't be like super groggy in the morning and tired to go to first grade. Like this isn't okay. You know, it's not right. And push your providers, push the doctors to do more about this, because I think some of them, to be honest, need that prompting a little bit. It's fine coming from me as a colleague, but I think coming from the public, we need to set that bar a little higher for our profession and what we do. So just to finish up on that, couple quick questions just to kind of touch on. One, there was a really nice aesthetic benefit and self-confidence benefit that you saw in Lauren, which again, it's not like every 6-year-old needs perfectly straight teeth. I'm not saying that, but when they do have teeth that are not there and we give them that beautiful braces smile at a young age, even with some baby teeth in there, I'll let you explain how that helped her and how she felt about that.
Oh yeah, no, it definitely, she has an absolutely beautiful smile right now. And she knows that she has a beautiful smile.
I love it.
Yeah, no, that definitely improved her confidence. You know, she can see the difference between what, you know, her smile looks like and what her peers' smile looks like. She knows there's a difference. She smiles more. You can see in the pictures, she's just, you know, huge smile, perfectly straight teeth, you know, a nice wide smile. I think in some of the pictures that you had given us, some of those before and after pictures, it did change her face a little bit,
yes,
as well. And
started
now
to grow
when
more
she
naturally. Yep.
Yes, yes. And now when, you know, we show her pictures of what she looked like before her braces, and she was like, oh, Mom, she's like, that's just terrible. She goes, I didn't realize it was that bad. And really, you know, too, just knowing that that one tooth that was protruding out was not going to get knocked out with a ball. It wasn't going to get hit by a friend and, you know, losing the tooth too. And then, you know, just obviously the airway is just a whole different ball game with that. But yeah, she knows she's got a beautiful smile now.
And I love that. That's the giving a young kid confidence. I don't mean to be making this an indictment of my profession, but I like to call balls and strikes and call the pros and the cons. And we do a lot of amazing things. Orthodontists are amazing people and really do wonders for their patients. I'll also call where things need to be improved and point that out. And we have this mentality, and it's unfortunate, like our national association, and we seem to be drifting further away from interceptive treatment and young treatment. It's, in my mind, the opposite of what should be happening. We're getting so focused on adult treatment, and not that we shouldn't also do that, but we're losing sight of the fact that we can do so much, as John so eloquently stated, with these kids when they're young and pliable and with less force and less discomfort. It's a kind of a point of sadness and frustration for me, because I'm so passionate about it and I know what's possible. So to hear you say how much she not only has a beautiful smile, but knows it, that's nothing bad. I mean, why would we want to deprive? So even if, let's say she had no airway problems and she just had some crooked teeth, you know, so many orthodontists out there would see a kid at 6'7" and say, you're too young for braces. Well, if they're self-conscious of it, it's like, just educate the parent. They might need a second phase down the road. I'm not saying we can fix it for, you know, permanently here, but let's go in for a little bit, give them a better smile. And there's nothing wrong with that. And that's okay too. And so even though that wasn't the main point of what we got doing with Lauren, it has that benefit. And I saw that time and time again. And I would have so many parents say to me exactly what you said, like their confidence just changed after this. They things I didn't even realize they were self-conscious of, or they then told me so-and-so was teasing me about this, and they never had told me that before. And now, everybody tells me what great teeth I have. Well, this is like a 7-8-year-old kid saying this. Kids are tough. Kids are tough, and unfairly so. And so anything we can do to help that. So you take a child like Lauren, and she's having sleep issues, breathing issues, leading to changing her behavior and her personality, and then would start to be more conscious of her smile not being what she liked. And you take that child, and in a little over a year, and we had COVID in the middle, so it lengthened things a little bit with the shutdowns. But in a little over a year, you take this child with 6 or so visits in between, and braces on, say 6 or so visits and braces off, and you turn them into a different human, and you change their quality of life and their parents' quality of life. It's super powerful.
So if we hadn't gotten Lauren braces put on until she was 12, I would assume that would be the average age of the braces. If we hadn't done that, instead of getting them put on when she was 6, that's a total of 6 years that Lauren would have gone untreated with sleep apnea. That's 6 years. That's a long time.
And not only is that a long time, it's also all of the neurocognitive deficits that could develop in that time, the academic challenges they can face, anything that comes along with being sleep deprived and having sleep disordered breathing. You saw those happening in her at that young age. Well, obviously the stresses, the intensity academically and socially only grow. So she would be having more of those challenges. And the way we grow, if she's mouth breathing and snoring, it's going to continue to constrict the growth of the width of the arch. So where kind of the percentage of narrow that her arch was at 6 would be a much higher percentage now. And the narrowness of her airway would be even greater now, because she would have grown in a less than desirable way because of the fact that she was mouth breathing and snoring, which squeezes everything in. So she would have even more dental crowding. She'd have narrower arches. She'd have a higher palate. She'd have more deficient airways. She'd have more of an extreme case of sleep disordered breathing and apnea. And then now you go in at 12 and try to reverse all that. And that's when oftentimes you have to extract a lot of teeth and be very aggressive on sort of the orthodontic process, and you end up in treatment for a long time. So that's an outstanding point. The last part I'll want to go into with Lauren and then I just want you give a little feedback, if you wouldn't mind, on how it contrasts with your particular orthodontic experiences. Tell me a little bit about the retention, the type of retainers we used, and kind of how long and how she's doing with them, and how stable things have been, and how the teeth have been coming in since then. In particular, one upper right canine, which was certainly destined to be impacted, and the genes were there impacted, and the genes are there for that teeth to be impacted, and where things are at now as she's a few years out of treatment.
As soon as she got her braces off, which she was not happy about, by the way, she was not happy to have her braces taken off. No, she was crying that day because she didn't want them taken off. But once she got over the fact that, she had to have them taken off, we had top and bottom, clear top and bottom retainers that she needed to wear all day and all night. Correct me if I'm wrong, but I believe it was 3 months.
You got it. Yep.
And the only thing that we noticed was probably for about the first week, she had a little bit of trouble just talking. And after that first week, she just adapted to having them in all the time. And she could take them out to eat. I know we had retainer cases everywhere. They were in the car. They were in my pocketbook. They were on the table. And, she would just very easy. She'd pop them out. She'd put them in her case. She'd eat. She'd throw them back in. At this point, she was about, I think 8. I think she was 8 at this point. So it's very easy for her to wear the retainers. And she did. She wore them, for the 3 months, all day. No problems. I mean, there was never a time where she's like, I don't want to do this, or they're not comfortable, or it was really a non-issue. We didn't even really talk about it. You know, she was excited when she got to just go to nights.
Yep.
She, you know, and people could now see her smile. You know, we
sure.
couldn't see it
Yep.
for 3 months because of the retainers. So she was excited to go to nights just so she could, you know, show off her smile. She wears the retainers religiously. She understands how important it is to not only keep her teeth straight, but to keep the palate where the palate needs to be, so that we don't have to go through this, you know, process again. And yeah, so it was, the retainers were really easy for her.
And you said the teeth are starting to come in now and everything's erupting nicely.
Yeah. So, you know, between the time that she got the braces off and now, she's lost a lot of teeth, a lot of adult teeth. And I know that as some of the teeth were coming in, the retainers were getting cut a little bit to make some room. Her teeth are still, the adult teeth are coming in exactly where they're supposed to be coming in. It's not, the retainers still fit. You know, and she is just about to be 11 next month. And she still wears them. They still fit. There's no problems. And the teeth are coming in exactly where the teeth need to come in. And, you know, and it's perfect. Absolutely perfect.
That's awesome. And then the second phase will be much different, whatever, you know, the in terms of the duration and involvement than what you went through as a teen. And then if you just want to kind of finish up by talking a little bit about what you saw Lauren go through by proactively doing this and going in and helping those arches grow and making room for the teeth, and how they've all come in and how that experience has been versus what you went through. And I know you've referenced that Lauren looked a lot like you, and shape of the face and growth was very similar to you at that age, and what your experience was.
Yeah, my experience with braces and Lauren's experience with braces is night and day. And I'm thankful and I am grateful that our experiences were night and day. We did have very similar mouths. We just have small mouths. We have very crowded, I think, mouths. My teeth were, my front teeth were also protruding, very, very crooked. And I ended up having to have 4 adult teeth pulled before they would put braces on. And that experience at that age, I think I might have had my braces put on when I was maybe 12, somewhere around there, but I had to have 4 adult teeth pulled before that. And I remember it very clearly, having to go in. I remember the stitches. I remember hanging over the sink, just bleeding, and the pain. I remember the pain and going through all of that. I would never, ever have made her go through that. We would have walked out of your office if you had said you were going to pull teeth. I would never put her through that. So that was, I still remember it. And, you know, they said my mouth was too crowded, and they eventually did close up the gaps. But to this day, my smile, even though my teeth are straight, my smile is not the same. They never expanded my arch. So my smile is still very narrow. I'm still very self-conscious of my smile. I'll take pictures with my mouth closed, even though I've had braces and my teeth are straight. And, you know, just the wires. I remember going to the orthodontist and going, oh, are they going to tighten the wires today? And, you know, coming home in just my front teeth just being in pain, even if my tongue touched my front teeth, eating. Every single time I had to get, you know, the wires adjusted. And I dreaded going back every appointment. And it was, I think, because my teeth were so bad, I was in braces for 3 straight years. And it was a lot. It was definitely a lot. And I would never, ever want her to go through what I had to go through with braces. And she didn't. It was the process. Like I said, this is night and day. This was the easiest process. It was so easy that a 6-year-old had no problems going through it whatsoever. Her process it was gentle. It was a slow process. It wasn't, all right, let's just, tighten wires and be in pain for an entire week. And then, all right, now you're okay. It was just a slow, gentle, almost more of a natural process, I would say, than what I went through.
Yep. Yeah. It's the story you told. I appreciate you sharing that. The reason for that, a couple of reasons, but the main one I'll focus on is they were treating the symptom, not the etiology or the cause. So they were treating the crowded teeth. And we often used to tell people, and unfortunately today it still happens, where you look at someone and you say, well, they have small jaws, so we have to pull some tooth mass. Well, how about we go in a little younger and grow their jaws so that they don't, so that those teeth, because it's not like you had big teeth. It's not like Lauren had big teeth. Teeth can look big at 6 or 7 when they come in because their faces are teeny, but there's measurements we have, there's averages and standards for what a tooth width should be. It's not some arbitrary size. So we know if teeth are like really big or not. Rarely is that ever the case. And if you look at the literature and that, it's rare. Nothing really out there conclusively supports that the majority or even a significant amount of crowding is due to big teeth. It's almost always due to narrow or insufficient jaw size. And so if you can help them grow and accommodate those teeth young and then naturally let those teeth grow into a natural position, even if you need a second phase to do the final alignment and get the bite perfect, it's such a minimal process and it's so easy and straightforward and easy for the patient, easy for the parents, and happens in a way that is just not what you went through. And that's really, again, because there's still a lot of colleagues out there who still look at these cases young and say, you can't help them grow young. It doesn't work. It's not stable. It won't change the need for second phase. It doesn't make a difference for later. If you just pull teeth, that's really the way you need to treat it. And we argue about this stuff as colleagues, but I guess in closing, what would you say to all the skeptical orthodontists out there who hear this or see some of the content I'm putting out there and are still like, I don't think that it's worth doing this the way Mike does it?
As a parent, I would want my child to go through nothing else but what exactly she went through. I wouldn't have changed a thing. The whole process was smooth. It was very gentle. She barely realized anything was happening. It just, after talking to my husband about, how it's a lot easier when they're younger to manipulate everything and then let it solidify, in the right spot, not having to go through having teeth pulled. It was just, I don't know why anybody wouldn't want to do what we did. There's nothing I would have changed. And I can't understand why this isn't standard practice, to be honest with you. And I thought it was standard practice until and I was excited that this was, night and day from what I had to go through, and the technology has improved, methodologies have changed. And, when I realized that this wasn't standard practice, I was floored, to be honest with you. And I hope practitioners can see that the whole process was just very smooth. It was just very gentle. And, and practitioners need to know that I wouldn't have had it any other way. No other way.
Well, thank you. And it's great too, because it's nice because you were skeptical in the beginning of it in a good way, I mean, 6-year-old kid, you're going to the orthodontist and you took a lot of time thinking about this. It's not like you just were like, yeah, fine. This is what Mike said, so let's do it. You went through a process and you really understood what we were doing, and you had some questions and concerns, very valid questions and concerns. And then you watched all of those concerns kind of subside as you went through this, and you watched Lauren thrive through this. And then you saw the airway and then the self-confidence and all of these things that happened, and then how easy the retention was and how stable it's been. And it's great. And I just can't thank you and John enough for sharing this with colleagues, with parents, to just say, hey, look, there's a different way to do this. And we need to keep pushing ourselves as professionals to do better for our patients. And getting away from treating kids young is not the direction we need to be going. We need to be doing more young, proactively treat the problem. You don't do this for everybody. You do it for the patients when they need it, but it's just so rewarding. And it's great for me. I mean, I love it. I love seeing the changes in kids like Lauren. I just love it. It fills me up. It's so, and seeing the changes in you and John. I mean, as I said to him, you guys weren't sleeping well. If your child's not sleeping well, even if you are asleep, you're worried about them, they're breathing. You've got busy, stressful days at work. We all do. And it's a drain on everyone's energy and resources that if we can play a role in that for the patients that need it, it's huge. And so I know that with people listening to this podcast and sharing it and knowing about it and talking to others about it, it'll start the discussion. And there are kids out there who will get help because their orthodontists will start to look more into this and do this. And there are Laurens out there who are suffering like she was without anyone really knowing why, who will have this change in their life. And because of you guys sharing your story. So I can't thank you enough for that. Yeah, I really, really appreciate it and appreciate you taking the time to be so open and honest about all this.
Well, thank you very much for having us and letting us tell you the story. If I could shout it from the rooftops, I would. This whole process is just so easy and just so smooth. And we really just hope, more practices can, offer this methodology to other parents, offer this to other patients. It's been fabulous. And we thank you for all of it.
No, well, it's my pleasure. And thanks so much for that. I really, really appreciate it. So it was great catching up with you guys. And again, say hi to Lauren and thanks so much again for it.
I will. Thank you, Mike.
All right. Take care. Thank you for watching this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to CE courses or schedule a private one-on-one coaching session with me. And remember to join the Doc community on Locals for more great content designed to help you succeed both personally and professionally. Just go to Locals and search for the Doc community. You can also find Doc on Instagram at @theorthocoach. And remember, you have the power to do amazing things.